You see, never waste a crisis. And I think that is exactly what I find that is fear is doing. So hats off to all of you. See, having said that, let us also remember that you see every disaster also leaves its own signatures, and signatures means that you can learn lessons from every disaster, you see, and it offers a window of opportunity. Now, coming to Gujarat earthquake experience, I used to be the joint secretary, and I'm talking of coordination and I'm talking of health, you see. That's why I'm mentioning through example. Maybe this illustration will be easier. uh, you see, it happened on 26 January, quarter to 9 in the morning. It was a holiday, it was Republic Day, so the whole government was on Rajpath, you see. And we knew from IMD that something serious has happened in Gujarat, but the extent and the magnitude of that was not known. Now, the first task in coordination was to call the meeting of the crisis management group, which is headed by the cabinet secretary. So I got in touch with my secretary, he got in touch with the cabinet secretary, and 3 o'clock, later in the day, we were sitting with the cabinet secretary, at least 10 to 15 secretaries and representatives of all the three defense forces, Army, Air Force, and Navy, sitting there. You see, and then the decision was taken. The problem, which uh, the government of India had to coordinate within itself because something big had happened, so at least a dozen ministries would be involved. It had to coordinate with the government of Gujarat. But how do you coordinate? There was practically no information because till 3 o'clock, only two phone calls had been there, that too only half, you see. Power had gone down and it was difficult to establish contact. It was virtually impossible. So the first thing which government of India wanted was what exactly has happened. It knew that earthquake has happened thanks to IMD. But how big? What is the magnitude? What is the spread of that? How serious is that? How many people, how many buildings have, there was just no feedback. And therefore, it was decided that a senior officer, and that happened to be Anil Sinha sitting behind my secretary. So when my secretary looked back, I said, "Look, Anil, you are gone, you see." And then it we went by the first Indian Air Force aircraft. Now, as soon as the decision was taken, then IMD chief who was sitting there, he said that we will send seismometers. One thing, you see, to monitor the situation. Second was health secretary. After all, the aircraft cannot go empty. That will be bad planning. So a dozen doctors, from each Safdarjung and AIMS, it was decided they would go. Then the third thing was, you see, we can take so much of drugs, and equipment. So that was decided. Telecommunication secretary said that, okay, satellite phones, because mobiles had just come, but they were not really so much operational. And we landed there, total darkness. Now by, I think, 8:30 or 9 o'clock, we were sitting with great difficulty. We were able to contact send a chit through a cycle to the district magistrate, who sent a bus later on, and then the whole team led by me, we went and met, you see, the district magistrate. So look at the kind of challenges one can get in coordinating in this kind of a situation when a huge event has taken place and telecommunication, other communication channels have gone down, you see. And then it started, I had to survey a whole night, and the hospital, the district hospital had come down, it has sat down, killing 179 people, etc., etc. So with these, let me just come to the last part of what I'm saying. The key actors which are involved in this kind of a situation, I'll just quickly read out because I know that one or two speakers, they have time limits. Ministry of Health and Family Welfare, Women and Child Development, NDMA, NIDM. Of course, NDMA was not there. NIDM was there. MHA, state government, then the district administration, police, NDRF, SDRF, they were not there, but now they are there. Fire services, hospitals, including private nursing homes, PHCs, CHCs, PRIs, ULBs, for the community outreach, then UN agencies, then NGOs, INGOs, Indian Red Cross Society, blood banks, database of donors, etc. other professionals like nutrition, Watson, this and that, then corporate people, then civil society, healthcare professional, educational, SHGs, volunteers, ASHA, Anganwadi, supply chain. This is just to mention a few. It is something like around 20 key actors and stakeholders which I have mentioned. You see, and then I just like to mention that WHO very nicely puts that there are 6 core building blocks: leadership and governance, HR, financing, medicine and technology, information, and service delivery. You see. So I just try to sum up, I mean, there's a whole lot of history. History means the actual experiences, which I can share later on if the time permits. But I'm just, I thought I have highlighted that in such a major, one of the biggest events to have happened in the last 2 decades in India, what are the kinds of challenges you can face at the national level, horizontally, vertically, from national level to state level to district level. The district magistrate was sitting under the tree in Bhuj because the district building, the collectorate building had practically been demolished, you see, damaged very, very severely. So with these remarks, let me once again say that coordination in these kinds of situations, especially health sector, which involves whole lot of, I think, pandemic, I need not elaborate, pandemic already has illustrated how huge the situation can be, and what kinds of, the range of services are required, the range of specialties are required. Like the doctors which went on that day in the aircraft, they could not be physicians, they were mostly orthopedic, because we knew that if it is earthquake, there are likely to be more bone injuries, orthopedic injuries, etc., etc. And then the drugs, etc. Also, equipments also accordingly. So one has got to tune and fine tune, accordingly. With these words, I will now end, and then I'll invite General Bindal, Executive Director of the National Institute of Disaster Management, to kindly give his keynote address. General Bindal, please. Hello, General Bindal, over to you, please. Hello. Hello.
So maybe you can have Tran first. I think he has to move out.
Can you hear me?
Yes,
Ah,
yes.
yes, yes. General Bindal is there.
Hello.
Yeah, yeah, yeah. We can hear you. Please go ahead.
Sir, good morning, sir, and thank you so much. And we are honored that you are there in this program to take forward this agenda of multi-sectoral consultation. And it is a very important topic on which we are talking about. We are because we are in the midst of a public health emergency of which has not been last occurred was 100 years ago, and hence no one is there who can actually recount what happened and how it happened. Hmm. So in this, what needs to be done is to consolidate the lessons learned that we have been able to learn in this whole issue, that such a massive scale pandemic, public health emergency, what all uh, challenges it proposes, and how it was overcome, and what should be the future action plan. So by the time this COVID-19 ends, at least for an epidemic or a pandemic, a uh, countrywide or country-wise solutions must be made. Second issue, which has come out very apparent, is that medical assistance or medical health care services are available to people who are able to go out, uh, mostly the men folk who are able to go to a dispensary, who are able to move around. But the most vulnerable section of the society, that is the women and children and the aged, they are somehow not incorporated automatically into the health sector. And that is the challenge in this. How do we reach each household so that everyone is taken care of? The people who are below poverty line, there has to be a dedicated platform, dedicated agenda to ensure that they are uh, singled out, given the required healthcare assistance, and monitored. And each one should be it should be put in the database and revisited at regular intervals of time. Uh, as of now, the health system that we have more is on need basis. If someone needs it, then we give it. Whereas the ideal thing should be that the person should not need it at all, that we are so proactive that we reach the person before the onset of the problems. He is or she is given the required assistance. So that is an idealistic point of view. In a country like India, it is not possible to have that type of structure, but efforts can be made that the women, children, and the aged, on the most vulnerable, like the persons with disabilities, are uh, 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 are given more focus, and efforts should be made to reach them through various community outreach programs, through various programs in which incentive should be given for the number of women being treated, for the number of children being treated, for the number of aged above a certain age being treated, so that more and more efforts and IEC campaigns are started so that they are drawn out and they are given the required healthcare services. I feel the moment we can reach out to more people, such vulnerable people, automatically the system will start improving. In India, we have a public health system, PHS system, which is down to every district level and below also, which has helped us a lot during this COVID-19. Unlike many developed economies where they had privatized the whole medical setup, and hence they had a number of issues with respect to healthcare of the needy. Whereas in our case, through the government setup, the healthcare was being transferred to the community at a very fast rate. Yes, capability or stockpiling for a particular one type of disease is not possible to an extent to which this COVID-19 has exposed us to. But yes, we should have a search capability, we should have a scalability contact, and we should have the training. The third issue, which I will talk about health sector, is the role of youth. In this whole pandemic, we have found that the youth has not participated. Youth has not participated as to the extent that in Mumbai, orders had to be passed for doctors to compulsorily report and register because there was no youth coming forward for as healthcare workers to help out the administration for such large emergencies. So it is very important that they are motivated. It should be part of the college, university curriculum, and colleges and universities should have more of practical aspects where the youth is promoted to do community service, so that it becomes as a culture among the youth of the country to come out to help out in such cases whenever required, wherever required. So with these three issues, I will close my opening remarks. Thanks to you, Professor Anil Sinha.
Thank you, General Bindal. Wonderful with your experience again, with a lot of clarity about what you want to say, and you have highlighted. But right now, I'm not really summarizing. Kindly pardon me for that, because Mr. Tran has another meeting at 11:30. So may I now invite Mr. Noon Nakyon Tran Min, who is the team leader at WHO India, to give his keynote address, Learnings from Global Responses, Strengthening Coordination for Health Emergencies. Mr. Tran, please. I hope I have pronounced your name correctly.
Yes, yes, sir. Good morning, all the speakers, speakers, panelists, as well as our participant. I see that around 60% on the line. So yes, thank you for giving me an opportunity to address this very important and very close to my area of work, that how we can strengthen coordination for health emergencies. First, let me go back just a little bit in history. As you know that the world had witnessed so many of these humanitarian emergencies, including pandemics. And since the 90s and also around after 2000, the United Nations come together, and they have what we call the Interagency Standing Committee for Humanitarian Emergencies Reform 2005. And there we institute what we call the cluster approach to ensure predictability and accountability in international response. This is the international dimension of why we think that coordination is so critical role in any of the emergencies, and now with the pandemic we have witnesses as well. So in this IASC, International Agency Standing Committee for Humanitarian Emergencies, WHO has a role. We are what we call the lead of the global health cluster. So now I'm very pleased to see that you have now, with the leadership of Sphere, as well as all partners, including WHO, UNICEF, all coming together to now drafting this. I see that you have now come up with this what we call health sector coordination handbook. Let me give an opportunity here to congratulate all the participants who have contributed to this. And I understand this is an advanced draft. So let's put our effort together to have come up with some kind of guiding principle for India, as let's say in international we have the IASC format and the cluster approach. You have the sector approach. So it's very much I see the connection there. All right, so I have just a few points that I want to raise that in terms of, I would like to highlight why the coordination is so critical for any response, and now in the context of the ongoing COVID. First, we all now seen and we have witnesses that no single country, no single institution, state or non-state parties has all the capacities to address the pandemic. Therefore, we need to work together for solution by applying science and solidarity. I think that I just now borrowed my Director General's in many of his opening remarks for the press conference in Geneva. Yes, we need to base on science and solidarity. So that's why coordination is critical role. So what we learned also from this pandemic, the second important lesson is that we need multiple strategies and interventions. Why? Because we know that biological, biomedical, like vaccine development is not yet there. We are very much advanced, but we need at the same time as much of what we call behavioral, what we call non-pharmaceutical intervention. What I'm saying here is that participation of the community, whole society. So when we have multidisciplinary approach, so different sectors need to come together. Therefore, the coordination plays so critical role that why the medical doctors, the scientists can now translate the findings, convey that to the community, that's wearing masks, keeping social distancing. So the not only biomedical emphasis on the response, but also in other sectors like anthropology and behavior science need to come together to fight this. And therefore the coordination working together is so critical. Another point I would like to raise is that it's not only about the partnership, but also the leadership, because without leadership, coordination will not take place. I give you an example, what you see now, just an example, for instance, how Hong Kong has been able to address and manage the pandemic so far, how Thailand has been doing that. So you see there, this difference make it with the leadership role of how the government, the health, and also beyond health sector have been able to communicate and to address this with all the intervention in the community. So we compare with some of the other countries in the world, as you see, without mentioning the name, why they have not been able to manage the pandemic as so far. So I really emphasize that the leadership role of any countries in order to have coordination, all the players, all the actors coming together. Another point I would like to raise as well is the partnership. Now, I would like to always say that WHO has been coordinating the response internationally, but what more important one examples, and I hope that you must, if you have not heard about that, you will have some of thought that what WS has brought together partnership for research on therapeutics, vaccine, and biologicals. We have what we come up with, we call the access to COVID tools. That all these vaccine and drugs at the COVID tools, we have what we call access to COVID tool accelerator, ACT accelerator. India and other, I think now 100 something, 40, 50 countries in the world, all the academic institution, philanthropies, and Gavi and others have been part of it. Governments have been part of this ACT accelerator. And it's a framework for collaboration. It's not an organization. It's not our guidance to do, but it's a framework how the whole world, all discipline, all countries come together in order we could have faster as possible vaccine, therapeutics, and other tools to fight pandemics. So I will stop my intervention here, but I wish you a very interactive and successful webinar today, and I'm looking forward to see how our health sector coordination handbook will shape up and will be disseminated to all the partners and actors on the field. Thank you very much, and I hand over now back to the host.
Thank you, Mr. Tran, for your very insightful and narration with the incorporation of experiences across the world. You started with this interagency IASC formation, in the UN system, to the cluster approach which is there, and which really ensures predictability and accountability. WHO, as we all know, is the global leader, you see, in the management of the current pandemic, and it has been doing that, you see, in coordination with practically all the UN members, you see. In India, we have sector approach, which is slightly different, but it is basically the same. And here also, I think in terms of coordination or collaboration, what you have pointed out, which is very important, is that no single country, no single institution can really manage this kind of a situation all alone, you see, because it involves whole range of dimensions, aspects of human life, human behavior, human response, understanding, etc., etc. So science and solidarity, as you said, that's very, very important. And then the leadership always matters, you see. And that's very, very rightly pointed out by you, highlighted by you. And what I like to say right now at this level is that leadership in our country, more so at the grassroots level. As we go down, ours is a huge country, billions of people, you see. And but out there, when we go down to the district and from district to the Panchayati Raj and to the villages, then the leadership, yesterday also I said that it is not just a question of talking about gender, but we need to raise it to the women leadership, women being empowered, their capacities being built, so that they can take leadership. Because I think in health, I think in food and nutrition, and practically whole range of issues, women leadership can be far more effective, far more humane in terms of approach, etc., etc. And then this your last point of partnership, partnership between academic, R&D, philanthropic, business, all kinds of institutions, which is now happening globally, in terms of search for the vaccine as quickly as possible, maintaining the ethics and the integrity of the whole process is something very, very important. So thank you, Mr. Tran. I think it's been very valuable inputs, which you have given. Thank you once again.
Thank you.
Now,
Thank you.
I'll go over to the next speaker. Just a minute, let me look at the, we have Mr. Luigi D'Aquino. He's the Chief of Health in UNICEF India, and he will be speaking on the role of his stakeholders in health emergencies, aspirations and challenges. So UNICEF, we know, plays a lead role in our country, and it will be wonderful to hear you. So may I now hand over to you for your keynote address, you see. Mr. Luigi D'Aquino, please. Yes, please. Over to you, Mr. Luigi. Can't hear you. Kindly unmute yourself.
Oh, here. Okay. Good morning.
Yes.
Can you hear now?
Yes. Please go.
Very pleased to meet you all. I'm very glad to be here today to spare some thoughts on behalf of UNICEF, taking the challenge of coming after my colleague and friend, Dr. Tran, of course, after our global leader in health response and other speakers. I will just share very quickly a few thoughts. To start with, I also want to echo others and congratulate this effort about the handbook that is being produced on multisectoral coordination. And certainly from our standpoint, we're very happy to provide support in finalizing this draft and also to make the draft a lively tool that can inform action going forward. With that said, of course, speaking to the logo that is behind me and the principles of it, I would say if I have to look besides and beyond India at how UNICEF as a whole looks at emergencies in the health sector and hence at coordination, the key founding principle for us is the core commitment for children in humanitarian settings. That is our approach to emergencies, and that very much speaks to the rights of children during emergencies. And hence, by itself, it calls to the full engagement of children and adolescents to start with, but also at protecting all of their rights across the board, from school to nutrition, to health, to protection, to play, to participation, and any other fundamental right there. So per se and alone, this creates a platform conceptually that speaks in itself to the concept of a multisectoral response and of the need of looking at concerted, coordinated efforts, even within the health response, because health at the end goes beyond a health sector. It's a much broader concept. Now, a consideration or two around COVID-19. I think COVID-19 is exposing us, has exposed us to something that is truly unprecedented. And I would truly hope that the scale and nature of the other emergencies that we will have to tackle after this pandemic will not be of the same scale. So I think we need to take stock of the fact that we are facing something that is exceptional. And in doing so, first, we need to think and act in an unconventional way. The usual responses will not work. The second is that we need, as we get going collectively in the response, we need to be smart enough to, and this effort really speaks to that, and I really thank Sphere and the COVID Academy for this, to collectively think and document the lessons of what has worked and what has not worked. And I know that we have always a tendency to look at what has not worked, but I think we need to be clever enough to recognize that there are many things that are working in these days, and also to be aware that in many instances, the rest of the world looks at India to learn, not only about how India is responding, but also to learn. I will give two very simple examples. India was testing 100,000 cases per day on average in May. It's testing more than 1 million cases a day today for COVID-19. So this is 4 months. India was barely capable at the beginning of the response to share or to equip its health workforce with PPE. Today, India is the second largest producer of PPE in the world. These two things alone speak by themselves to a success of a multi-sectoral response. So what I'm trying to say is, let us try to take stock of the lessons and to document and share. And there will be gray lessons, there will also be rosy lessons to learn and to share. Another consideration I wanted to bring about coordination. What is the platform for coordinating? And sir, yourself have really named all the key stakeholders. I don't really need to add to that. But I think within the health sector, when we speak about emergencies, we have two challenges in one. It's a dual challenge for us within the health sector. One is preparedness and response to the health-related emergencies, the outbreaks, the epidemics, and now the pandemic. The other is to make sure that the health sector is prepared to respond to non-health emergencies. And the example of the earthquake, floods, cyclones, and others are very clear example. So within this sector, we have the dual role and dual challenge and dual task of being prepared on both fronts. Where does it all come together? I'd like to bring the attention of participants to the very concept of a strong and resilient primary healthcare system. I think that is the key that brings together both elements of preparedness and response and brings together all the actors. If you look at the framework that WHO has produced and shared globally about primary health care, at the center of it, there is people. And if you look at the core that is required, one of the key actions is around multi-sectoral planning, policy and planning. So I'm really seeing this COVID as an unprecedented opportunity to make our primary healthcare system stronger. And there are two ways, and then I'll stop, two directions I think we need to consider collectively taking. One is on the preventive side, the preparedness. So, and the other is, of course, the response. On the preparedness front, I really would like to echo my colleague Tran. One critical piece is leadership. And I want to bring leadership to a more simple and perhaps simpler concept. I think preparedness is all about a mindset of an issue of a mindset, having the mindset and the culture to bring some marginal activities that will yield enormously high returns at planning stage. How many assessments are done every year within the health sector, in one district or another, in one state or another, by one NGO or another? What is the marginal cost of including in there the assessment of the resilience of the health facilities and preparedness to responding to emergencies, or whether the infrastructure is fit to accommodate floodings or other similar emergencies? Marginal cost is probably zero. The evidence that comes from that is huge for action. Similarly, how many trainings are done every year in service, pre-service, from ASHAs, ANMs, healthcare facilities providers, district managers? What is the marginal cost in any of these sectoral training, be it IPC, be it skill delivery, be it neonatal care, I'm mentioning some randomly, of adding one or two modules on emergency preparedness and response? Zero marginal cost, hugely beneficial in terms of benefits. So there are very small steps in terms of preparedness that, to me, in my very limited knowledge of India, I only have got 1 year of blessing in working in this country. So I really do not pretend to bring any lesson, rather just sharing thoughts in my whole ignorance of the enormous experience that India has over years in public health and in health emergencies. So please take this as simple thoughts rather than anything else. So one side is preparedness, the other side is response. And I think the core of response has been mentioned. What I would like is to provide one or two additional reflections about what else needs to be done. And in that, on a UNICEF standpoint, I would really like, in addition to what has been said, to stress the concept of social accountability during response. We need, and there are mechanisms, and in these days, the technology help us. We need to find ways. There are examples in Kerala, very well documented, of listening to people as we take and shape the response. Because at the end, the response needs to be shaped according to the needs of the populations. The other is, and big learning from COVID, to find ways to have from the onset the involvement of private sector, and I'm talking private sector not only in terms of business, but also private sector providers. How crucial will they be in a response like this? And how can we involve them? The media, we need information to be flowing out, and we need to contain the misinformation that goes out and that can bring people to take wrong behaviors. We need the adolescents, we need all the channels for behavior change. And of course, we as UN partners, and Dr. Tran spoke to that already, I will not repeat it, play our small part into this. And very happy to do it to the extent that is possible and useful to the response that is undertaken. I would stop it here, and again, one last word for what has worked or what not. I think the concept of a whole of society, whole of government approach is a concept that we should not underestimate as an overarching philosophy and framework of action that has taken shape, the response to COVID-19 in India. So let us build on that. Let us build on the efforts from the Sphere Academy and bring these lessons forward so that the next emergency will do even better. Thank you so much. Sorry if I spoke too long. And sincerely, thanks for all these efforts. Over from me.
Yeah, thank you, Dr. Luigi. I think it was wonderful. You didn't speak even a minute, extra. I think every word which you spoke is so very relevant and important and critical. UNICEF, we know, thanks to our colleagues there and the active UNICEF team, has been, in the leadership position in our country, not only at the national level, but in states also. I know for certain for Bihar, where the local, the Bihar UNICEF office in Patna has been very, very active, in school programs or other programs or pandemic, etc., etc. So I'm very happy that you participated, and you rightly emphasized the need of providing a platform for multi-stakeholder coordinated approach, you see. And COVID-19, of course, our friend from WHO may have left, but let me just make a point which I should have made right in the beginning. Somehow or the other, I find that COVID-19 is may become a misnomer later on, because like the epidemics which took place, 100 years back, we still talk. So COVID-19, as we say, will be talked about next 50 years or 100 years for its vastness, for the impact, overall impact on the people, on the economy, on everything. Now, when we say COVID-19, it looks as if there was one COVID-18 also. It looks as if there was a 17 also. So 19 is something like a serial number. I thought WHO should really re-christian it and rename it as COVID 2019, because even 100 years later, COVID 2019 will never be taken as a serial number, while 19 can be taken as a serial number, as if there was 18, 17, or as if hopefully not, there will be 20 and 21 also, you see. Well, that is my view, but I really honestly feel this. Then I think you understood a very important point of collectivity, collective thinking, uh, coming together as a collective, various constituents of the society, of the government, whole society approach, whole government approach. And I'm happy that you mentioned about the leadership role, you see, and the resilience which has been shown, and the initiative, leadership which has been shown by India from 100,000 testing to come to more than 1 million testing per day. That is, in fact, shows how we can scale up our own operations. That is the kind of a resilience. We learned the lessons very quickly, and we have been able to raise it to that level. And similarly, these masks and PPEs, India was not producing even a single mask or a single PPE kit, you see. And now, as you said, we are the second largest. So I'm happy that our country has been able to really come up together and meet these challenges right from the facing the challenges right from the fourth lock kind of. And I'm sure there are many such good examples and practices across the world which we should be learning from. While we may have done this, but there are many countries, many societies which are having very good culture and behavioral systems, which is there. And the last point which I like to say, which I really highly appreciate, is the strength and the resilience of the primary health care systems. I think that is lies at the that is the bedrock of the whole health response. And here again, I think the number of CHCs we have, the number of PHCs we have. In fact, as you know, we have additional primary health centers also, which provide the outreach to far off villages which are away from the PHCs, etc. So, and that is what ensures that people are at the center of the whole strategy, as you put it, because unless until people are at the center, I don't think that we can't really be working in vacuum, and we can't really succeed, you see. uh, and finally, your two directions, the vision which you give, preventive and response, you see, I think they are very, very useful. So thank you, Mr. Lugi, for a very insightful, very sharp, and very good points which you have shared. Thank you once again, and God bless. Yeah. May I now invite the next speaker? We have Srimati Bindu Mohan.
Sir,
Bindu Mohan, Additional Director of Health Services, Medical Kerala, and she will be speaking on preparing for future pandemics. Dr. Mohan, I had the opportunity to be in Kerala last year for about 2 weeks, and I also had the opportunity of meeting your wonderful minister, Lady Kumari Salja, and personal meeting with her, which was very, very inspiring. She related her own experiences, how she led the Nipah virus challenge, and then the floods in the state in 2018, etc. So it will be wonderful to hear from you. So Dr. Bindu Mohan, over to you, please.
so Dr. Bindu is facing some problem. She said she'll try to reconnect in 10-15 minutes.
Oh.
So in that case, perhaps we can close this with your remarks and then start the panel discussion. Once she joins, we'll definitely immediately give her the space to speak.
Okay. Yeah. Well, I would say that the speakers in the inaugural session, they have really highlighted some very, very important and critical aspects of the overall coordination, and especially relating to the health. Health, as I said right in the beginning, is something which requires a highly differentiated kind of a response. You see, if it is earthquake, you need one kind of response. You need one kind of specialists or the doctors going there. If it is flood, and then there are water-related diseases, etc., it's an entirely different situation. You see, in all these situations, then we have vulnerable people. There are children, there are women, there are people with comorbidities, etc., etc., and then there are elderly people, who have their own challenges. They have their own morbidities. So I think they require the special attention, even over and above whatever is this the given situation. You see, so I think, and then health, as COVID has shown us, you know, the very workers, the frontline workers of the health sector, the doctors, you know, the medical personnel, the paramedic staff, nurses, other staff, etc. They themselves are exposed to this kind of a situation right now. What we are saying, you see, and supposing there is an earthquake, then as I think I mentioned, that the hospital, the district hospital itself, the very facility on which you depend, you know, to respond, had come down. You see, it was just non-existent. It needed to, you know, rescue, etc., etc. There were people down there who were buried and who had survived, and in the dead of the night, I could hear the voices of the survivors. You know, that is one challenge. And then the doctors who have gone, and there are injured people who are being rescued and brought from all over. You see, in that kind of a situation in 2001, army hospitals, you know, and in the field, they had provided. Now the doctors, you know, which who went from Delhi, Safdarjung and Ames, they were the brightest of the brightest, you see, young guys. But I do not know. I don't think they were trained. They were trained for some ideal conditions in the OTs and with all kinds of facilities. And here they are exposed to an open situation where the support systems are already highly challenged. You see. So therefore, given all these little bit which I have mentioned, I think health sector offers tremendous amount of challenges, you know. And but I think it's a very good thing. I'm very happy that sphere is undertaking this exercise. But I like to once again emphasize that we'll have to take this exercise down to the level of the STMAs, work with a large number of STMAs in the respective states, and then the DDMAs, because ultimately the action, the implementation, ultimate mobilization of the resources, be it medical, be it health, be it personnel, be it blood bank or whatever, takes place at the district level. See, and then, you know, in terms of reaching out to the people, then the panchayati raj institutions, the urban local bodies, the municipalities play a great role. In Maharashtra, I'm told, as far as the Mumbai is concerned, the Mumbai pandemic is being managed entirely by the municipal corporation of Mumbai, Brihan Mumbai municipal, you know, metropolitan, which is there. The state government is involved in the management of the rest of the state. You see, so that is one example. Maybe Mumbai example doesn't really correspond to many other cities, second tier, three tier cities. But I think the role of the urban local bodies, that is very, very important to see. So with that, in case there are any questions, I have not been able to read the chat box, you know, because I was focusing on the speakers. So in case there is any important or burning question, we can take them for any of the speakers in the inaugural session. Otherwise, we can conclude the inaugural session and move to the next panel discussion, please. Hello.
There were some questions regarding COVID vaccine, and in the chat box itself, Luigi has responded that look for COVAX. So I think it's already responded.
Okay, wonderful, wonderful. So I think with these words, then I like to conclude the inaugural session, and I don't think we have any other speaker. So may I now hand over the today's discussion to Dr. Hena Hazazi, who is the Knowledge and Capacity Sharing Manager, Sphere India, to kindly take over the panel discussion, please. Dr. Hena Hazazi, over to you, please.
Thank you so much, Professor Sinha, for such an insightful, enlightening, and enriching session. We have come out with a plethora of suggestions and recommendations, which would certainly feed in our research documentation for future reference, especially vis-a-vis the handbook that we have come out with. So I'd like to, before we proceed with the panel session, I'd like to just consolidate some of the recommendations that have come and the key highlights of the sessions that have happened in the morning, the inaugural session. Which General Bindal has reiterated the importance of vulnerability of women and children and emphasized the importance of how we can reach out to each and every household and the monitoring process. So thank you, General Bindal, for your suggestions and recommendations. TRAN has emphasized the role of the Interagency Standing Committee for the Humanitarian Agencies for lending more accountability to our processes. He has also flagged the need to work together for solutions, science and on science and solidarity, and need for devising multiple strategies. What I really liked about is that he talked about the behavioral aspects and the non-pharmacological interventions that need to be in place. He's talked about the importance of leadership, which Anil sir also reiterated with saying that women leadership and leadership of the community play a very pivotal role in responding and preventing and for better preparedness and response. He also emphasized the partnership for research and talked about the framework for collaboration on vaccine therapeutics. So of course, this will be included in the this one. Louis, some of the suggestions that came from Louis were like to work collectively and to he emphasized on the importance of the documentation of good practices in the form of lessons learned. He also talked about some health actions and he also talked about health actors being better prepared for addressing and responding to non-health emergencies. He talked about the critical leadership role in the preparedness aspects and the assessment of the resilience of health facilities and how we have to invest in preparedness and stress the concept of social accountability and the role and engagement of private sector providers. Thank you all so very much. It has been a very, very enlightening session. Listening to Anil Sinha ji has always been a feast. He is an institute in himself. And with this, I'd like to welcome all the panelists for today's sessions who come with a diverse and rich experience in the field of health. I've personally had the privilege of working with some of the panelists who are on the panel today on different occasions. And I'm aware of the work done by each one of them in establishing and strengthening a decentralized health resilience approach in their respective locations and contexts. So today's consultation on health, besides providing a platform for knowledge sharing, should also be an opportunity for revisiting and reviewing the zero draft of the Health Sector Coordination Handbook, which has been developed after multiple consultations with Spare India members and sector experts. This handbook goes deeper into each aspects of coordination vis-a-vis role and functions, assessments and monitoring, strategy, benchmarks, resource mobilization. We hope and pray as we delve deeper that at the end of today's panel session, we are able to come out with, to have the government's perspective on how assessments, for example, how assessments can be done in a more coordinated manner, how to agree on certain benchmarks. I'm sure the recommendations that have come in the morning will further be delved deeper during this technical session. With this, I invite the first panelist for today's session. May I please invite Professor Anil Gupta ji, who is formerly Head Director, Institute of Environment and Development Studies, Bundelkhand University, Jhansi, since 2003. He joined NIDM in 2006. He specializes in disaster mitigation and crisis management and holds a PhD and postdoctorate for the same. He has over 100 publications, including 10 books and 45 papers. He is the coordinator of the Technical Advisory Committee of NIDM, member of the Governing Council and Academic Research Advisory of several institutions and high-level ministerial delegations abroad. I hand it over to you, Professor Anil Gupta ji, and over to you, sir.
Thank you, Dr. Hina. And Shri Anil Sinha ji, Vikrant, the entire team of organizing this webinar series on a very important dimension, which is a sectoral approach. In fact, that directly goes with the item 1 of the Prime Minister's agenda, 10-point agenda on disaster risk management. So, because the point 1 says that all the sectors of disaster, all the sectors of development need to imbibe the principles of disaster risk management. And particularly today's discourse, which is focusing on health sector, is very important, because even a layman would agree to this, that the real property that we have is our health. And the health implications of disasters are so critical and so widespread that it requires a very systematic approach to address this dimension. Now, I have noted a couple of points that I would like to share here. That until very recently, the focus on holistic health has not been there, especially in developing countries like ours. And the emphasis of the medical system has been more on clinical health, or the kind of a curative approach. But past 10, 15 years or so, there has been a great paradigm shift in the entire health system, that we are giving equal emphasis and equal focus on this new concept of the holistic health. And when we talk of holistic health, this particularly this 7 months, 6-7 months, past 6-7 months of the COVID-19 pandemic, in fact, that has brought this holistic health dimension into the forefront, because in the COVID-19, uh, though we are also talking of the clinical issues, but we are also finding that even the mental health issues, even environmental health issues, water sanitation issues, disease prevention, the comorbidity issues have emerged as kind of a very critical issues coming to the forefront. So this is a great paradigm shift in the health sector itself, in the social and preventive health, and therefore in the entire gamut of disaster risk reduction. And when we talk of this holistic health, we cannot do away. Yes, environmental health is certainly very important, because the disease prevention before disaster and disease prevention after disaster, both are important. During and after disaster, both are important. But beside this, the issues of occupational health have also emerged very important, because as SPR is a national coalition of the response and relief agencies, and many a times we find that the responders' health uh, also critically important, but is rarely considered as an important issue in our disaster management plan, or the relief the kind of a discourses. So this occupational safety or occupational health dimension, looking into the disaster responders health. Then beside this, industrial health also emerging very important, because now the kind of amalgamation that we have, especially in peri-urban systems, that we have urban populations, we have the rural population, and we have the people who are living in some other place, working into some kind of a manufacturing sector and industrial sector. So this industrial health is also becoming very important. Now, why this issue I am finding very important, because nationally we have this mission called Swachh Bharat Abhiyan, and this Swachh Bharat Abhiyan directly has a synergy with the I would like to call it as a kind of a Swasth Bharat. So health for all in India, or we can say that the Swachh Bharat is can have a consequence in terms of the Swasth Bharat. Then two major dimensions that we consider in disasters and health, when we talk of these two things together. Then health consequences of disasters, like many disasters, for example, earthquake has the consequences like deaths, but disability, injury, all these kind of things also, chemical accidents also, similar kind of things. But floods, drought, these kind of waterborne disasters, water-related disasters are having an entirely a different kind of a sequence of consequences. So it is not a one-day kind of thing, or immediately you cannot see the consequence, but a series of other factors are involved into bringing the consequence. Then the other aspect or the other side of this coin is the health episodes itself taking the form of disasters. So like COVID is a environmental emergency that started as an environmental emergency and then rose to the level of a major health emergency. So this health emergency itself became a kind of a global disaster. But besides this, even the Japanese encephalitis, other kind of a pandemics, some kind of a Zika virus episode, sometimes even the contamination related issues. So health episodes itself taking the form of disasters. So these are two the points of this interface. I would also recall to the initiatives from international agencies like WHO. I think it was 2000 or 2001. They came up with the international guidelines on dealing with the environmental health during disasters and emergencies. And I think the United Nations Environment Program also has jointly come out with some kind of manual in the environmental health issues in the conflict areas and also in post-conflict development situations. And many times these things are almost similar when it comes to the planning for response and relief, focusing on the health issues in such situations. In fact, starting 2015, we from NIDM, we have been collaborating with the ICRC, International Committee of Red Cross and Red Crescent Societies, WHO and Indian Red Cross for organizing an international program that is called HELP, that is health emergencies in large populations. So that is a 2 weeks very specialized kind of a hands-on program that we have been organizing. So there actually we take this thing that how health emergencies in large populations can take the form of a big disaster itself, and disasters have the health consequences. So both kind of dimensions, but also this climate change has now emerged as a major contributor to hazard and vulnerability both. So we are taking that also in this. Then another issue that I would like to flag here that we have been discussing with the medical education fraternities. For example, the courses, the institutions running the course like MBBS, BAMS, and the other alternative medical programs, and also the MPH programs, health management programs. And what we found that in India, in fact, for quite a long time, the emergency medicine and community medicine has always taken a backseat until recently. Now, after this emergence of the new focus on holistic health, now we have realized that this issue is very important. And as on now, the dedicated curriculum on disaster risk reduction issues or disaster relief issues related with health is not prominently a part of the curriculum. But now some institutions have started. We have been working with the nursing associations also. We have been also supporting medical and nursing institutions, health institutions in integrating these topics into their courses. So that is also a requirement that we have filled, and we have been trying to push this issue. Then another point that I would like to share here that under the National Action Plan on Climate Change in 2019, when 3 new missions were added. So National Health Mission is the one of the 3 newly added mission. And under that, NIDM has taken lead jointly with Ministry of Health and Family Welfare and also support of WHO in preparing the National Health Adaptation Plan for Disaster Risk Reduction. So that is basically disaster-related illnesses, how we deal with that, and also focusing on climate change implications that is aggravating these kind of things. So we have recently come up with that plan, and now we are also trying to develop a pilot implementation plan in 3 states of India, so that we can really see that how the plan can be executed at the local level and within the states. So the focus is on health. When we say health sector, so we are also looking these from 2 dimensions. So that health systems and a health infrastructure. So health system includes your manpower, your inventories, your management systems, data management systems, the effective early warning systems in terms of health consequences. Now we are, like we have developed the agro advisory services, looking to the futuristic climatic scenario or futuristic disaster risk scenarios. We can do some kind of forecast that how the agriculture is going to be affected and what are the new challenges agriculture is going to face. And therefore, on the same way, now we are trying to work at health advisory services. So looking at the disaster risk assessment and disaster early warning, we are trying to work out some kind of module that we do health forecasting or health challenge forecasting, so that the required inventories, required trainings, required capacities can be brought in place before these kind of challenges arise. So we also recently come up with a compendium of case studies on health consequences of disasters, developing a toolkit, training toolkit for the training of health and non-health but associated sector officials. So these kind of things are there. Then we are also working to integrate the district environmental action plan, which is now being developed by all the districts as per the directive of by the Green Tribunal in India. So we are also looking at the kind of convergence which is possible about the health adaptation plan, environmental action plan, disaster risk management plan, and climate change adaptation plan, because things go hand in hand. Then coming to mobilizing the resources and the financing support, there are 2 dimensions we are trying to focus. One is that integrating health as component within the risk assessment. So we and also in the environmental impact assessment process. So we are focusing that how to integrate health impact and risk assessment as one of the sub module within the environmental impact assessment, auditing, and also the risk assessment process. And beside this, the new approach, which is a more scientific approach of post disaster damage and need assessment, has very specific module integrated on the disaster impact on health system, health infrastructure kind of things. So these are the things. And lastly, I would like to focus that since now everything boils down to economics, so until unless we bring the focus on health within our the occupational settings, within our work environment, the holistic focus on health would not be possible. And hence, how disasters affect health, and then how health affects our business. When I say business, not necessarily it is a profit-making system, but any kind of entrepreneurship, any kind of work environment. So disaster, health, and business. So this the interface between the 3, I think, has to become one of the key focus of the coming time, especially in the post-COVID redevelopment scenario. And then finally, all these kind of the lessons from the discourses, policy initiatives at the national level or also international level, finally have to go down to local level. So district level interventions, I find that very important. And that is the reason in our National Health Adaptation Plan for disaster related illnesses also, we have recommended that the plans at the district and sub-district level, and on the other hand, if we talk in terms of health system, I would say that the district hospital, then health center and sub-center level are important. So these are the kind of a few points which came to my mind, and I thought of sharing at this occasion for consideration by the experts, panelists, and all the stakeholders. And thank you very much for giving me this opportunity to share my thoughts. Thank you, and over to you, Dr. Henna.
Thank you so much, Professor Sinha. It was indeed very insightful, very comprehensive, very exhaustive information. And you talked about the tools, inventories, various research and documentation work that NIDM is into. And we would certainly want to kind of incorporate some of the findings, recommendations, and suggestions that you've just now highlighted. You've largely talked about the importance of holistic health, and prioritizing emergency medicine and community medicine, which was not prioritized earlier. You talked about the integration of the health course, especially which turns out to be such an important thing in today's context, which talks about a whole variety of an amalgamation of so many other health issues, because health being a cross-cutting issue. So we also try to do some work on strengthening emergency health emergency preparedness and coordination in Meghalaya, Mizoram, and Manipur. In 2016, where we were trying to come out with some spare minimum standards are 19 in number, and these are very comprehensive. They come out with indicators and all. So our state disaster management plans and state health plans do not have exhaustive and comprehensive SOPs on health, like what health should follow. So that was our humble exercise with the support of WHO and some other actors, with the NDMA and with some other international organizations who are working on health issues. We try to develop some draft TORs for the task forces for the state and district level field functionaries, which include the health and non-health sector partners, and came out with an action plan which was submitted to the government of Meghalaya, Manipur, and Mizoram in 2016. So similar initiatives need to be kind of rolled out in other contexts and in other communities. Now, to take this forward, since we have a lot of panelists in the session, we would like to adhere to a specific times allotted for each session, so that we can have we can accommodate all the other panelists. I call upon Dr. Jitesh Vittila Kathaji, who is the Assistant Director at the Department of Health Services for the Government of Kerala. He has also served as the District Program Manager at the National Rural Health Mission, Government of Kerala. I know him as a very good and efficient gender trainer, who ever talked about health professionals not being good at other things. But gender-based violence, I mean, he's very passionate about it. And he is the one who's trained me on gender, is my first trainer. He's also co-authored a book on minimum initial service package for sexual and reproductive health in disasters, which was a brainchild of NDMA, technically supported by UNFPA. So over to you, Dr. Jitesh. We will try to adhere to this timelines. Okay, I hand it over to you, Dr. Jitesh. Dr. Jitesh, are you there?
Dr. Henna, I can see someone with the name of Jitesh, but he needs to be made co-host so that he can unmute.
Okay.
Hello?
Yeah, Dr. Jitesh,
yeah, just a minute. Let me share my screen now.
Yeah, it's visible now.
Okay. Okay, thanks a lot, Dr. Henna, and also Mr. Vikrant and Ultimate Sphere India for inviting me for this session. I'll be talking more about from the implementation side, based on the experience of Kerala, especially on two issues, especially on the COVID-19 pandemic issue. The success of Kerala, or so far the success of Kerala has been highlighted in many fora. Maybe our success partly depends on a trial run we had with Nipah in 2018. Where the people the public walking around in mass is not a new sight at least in some parts of Kerala. in 2018. We also had severe floods in 2018 and 19, which also was managed by multi-sectoral teams very successfully. So by the time we had the COVID pandemic, Kerala already had two well-planned strategies which had proved successful, so that we could go into the COVID pandemic with a relatively successful plans in mind. So the intersectoral coordination, which is often talked about but not successful on practical terms, in Kerala it is relatively successful for the last many years on many aspects. And in terms of COVID-19 pandemic, the intersectoral coordination starts from the topmost level. Though the action mainly is at the grassroots level, the planning itself starts with intersectoral coordination. You can look at the profile of the expert committee members who decides on Kerala's strategy of tackling COVID-19, especially on relaxations of guidelines related to lockdowns, sending out guidelines on management of COVID-19 pandemic, including in health sector and in other sectors. We have a filmmaker, a Dada Saheb Phalke Award winner, who is a representative of the public. We have two persons from the media sector, top brass from the media sector. One of them, Mr. Shreyams Kumar, is also a member of Rajya Sabha now. We have a bishop, we have former secretaries, former DGPs from the police, we have a senior advocate, we have a former additional chief secretary who was in charge of health at the state level and also worked at the national level for a long time. We also have people, doctors who are multifaceted, like Dr. Iqbal, who is a neurologist as well as a people science activist, Dr. Khadija Mumtaz, who is also a gynecologist as well as a writer and the chairperson award winner in literature. Dr. Murali Tummarugudi who is the operations manager of the UN Environment Program. The profile itself speaks a lot about how we have taken extra effort of bringing in expertise from all sectors into the state level decision making team, and that goes a lot into the lower levels also, because the decisions made at the top level are a part of a discussion of a multi-level team, multi-sectoral team. There is a team at the district level and also at the local self-government level, and even lower down up to the ward level, which is the component of the local self-government. We have rapid response teams consisting of people's representatives, the officers from the different departments, as well as the public and volunteers, and the local self-government representatives who are running the show at the grassroots level. The backbone of Kerala's success in intersectoral coordination as well as success in COVID-19 management is mainly two. The first is the robust public health sector of Kerala, which has been there since the time of the Rajas pre-independence era, and also the very successful implementation of the Panchayati Raj setup in Kerala, which actually took the power directly to the people themselves, to the most downtrodden people in the community. So these two successful models already existing in Kerala, and has helped a lot in tackling all health emergencies as well as non-health emergencies. The Panchayat Raj institutions has been the spoke, like the hub of the intersectoral coordination at the grassroots level in every activity, including during emergencies. So even in COVID-19 pandemic, it is the Panchayat Raj institutions, the local self-government, which spearheads the action at the local level, coordinating all departments as well as the community. Every action related to control of the pandemic, from contact tracing to home quarantine, institutional quarantines, entry and exit of travelers, transportation of patients, dealing with migrants, dealing with special communities like the tribal community, women, pregnant women, children, vulnerable groups of people. Everything is done by teams which come from different departments as well as all including volunteers from the community itself. So the multi-sectoral teams are entrusted with the activities of COVID-19 pandemic prevention and control, and each team member, each sector in the team has very clear guidelines of what they are supposed to do. So there are department level nodal officers. Each department has appointed a nodal officer to deal work in the multi-sectoral team, so that coordination becomes easier. There is an interdepartment core group at all levels, from the ward level at the lowermost level to the state level. The LSGA, as I said earlier, has a lead role along with the state and district disaster management authorities. Media has been a big support, apart from the usual style in Kerala, where there is a lot of fault finding. In the case of Nipah, as well as later in the case of floods, and now in the case of COVID-19 also, there's been a very active support of media, appreciating the good work as well as providing necessary messages to the people. Also countering any false propaganda that comes up in social media. This has been the responsibility of the media, which they have done very well. And even departments which are not actually in line with the action, like the tourism and transport corporation and the other departments, have also been given very definite roles, which I'll be dealing with a little bit more later in the next slide. So even those departments who actually consider themselves not involved also have been involved in the COVID-19 pandemic very well, because this was a pandemic, and the support, maximum support that could be mobilized, had to be mobilized. The police department, each department had a very specific role assigned to it. Fire and rescue usually is not involved in health emergencies, but except in rescue operations and non-health emergencies. But here, fire and rescue had a very definite role in disinfection of public places and also accessing difficult to reach areas. Media I have already talked about. The labor department was entrusted with the task of looking at migrants, which is a very large community in Kerala. A special plan was worked out for migrants itself by the labor department in consultation with the multi-sectoral team. Tourism department took up the responsibility of providing accommodation for the staff who were working in CFLTCs, and also for setting up quarantine centers. Even, for example, in many of the hill stations, the resorts were taken up for CFLTCs as well as for providing accommodation for healthcare workers. In Alleppey, places like Alleppey, houseboats were roped in for accommodation, similar as well as for running CFLTCs. So each department had very specific roles assigned to them by the district disaster management authorities, as well as the local self-governments at the district level and at the grassroots level. So technology, since meetings were not possible, the whole of COVID-19 pandemic was managed maybe using technology. And the COVID-19 Jagrada portal of Kerala, the many activities are run through such portals. But the difference I have noticed in the COVID-19 Jagrada portal is that when you enter as a health professional, you are going into an area where your role is needed, whereas somebody from LSGI entering into the same portal, they go into an area where their role is maximum. So each department, it is a one-stop solution for all the departments. Usually the data is collected and managed by each department separately, but here there was a single portal which looks at everything from entry of travelers into the state to the management of patients in category C who are admitted to COVID care ICU. So the whole spectrum is managed through this one single portal, which has made a lot of difference in coordination, which has improved coordination to a very large extent. There's something called a COVID brigade set up in Kerala, where a lot of volunteers from different aspects, from doctors, specialist doctors, to the normal public who are willing to donate their services, have been registered through the COVID-19 Jagrada portal itself to the COVID brigade, and they are recruited for various activities. So there is a multi-sectoral team of volunteers as well who donate their expertise to various aspects of the COVID pandemic prevention. So as of now, as of yesterday, there are 18,808 persons registered, of which more than 9,000 are medical professionals, and the rest more than half are about non-medical professionals who have lended their expertise into this aspect. And one thing which I have noticed has changed a lot. The coordination has, yeah.
Your time is over, Jitesh.
Yeah.
If you can please.
Yeah. Yeah, I'm stopping in a minute. So the one thing that has made coordination a lot easier is the use of newer technologies, newer group formation tools like the WhatsApp, which has made coordination very easy. And just half a minute, I'll just talk about one aspect which have been a successful model of intersectoral coordination, which is Bhumika, which is the health sector response to sexual and gender-based violence in Kerala, which has also been a model for other states. So it needs a multi-sectoral approach, and it is done through an intersectoral coordination committee, which has been formed since 2009 and which has been functioning very well, coordinating different aspects of the from lawyers, policemen, health service personnel, and the public, as well as the local self-governments. So the intersectoral coordination has been a successful example in the Bhumika domestic violence management initiative also. So this is how Kerala has been successful to a large extent in intersectoral coordination. So the lessons learned, especially from the COVID-19 pandemic, is the importance of decentralized planning, and each department has been given proper ownership. Instead of the health department leading the team, each department has been given a specific ownership of a part of the program, so that it has provided as I said, Nipah has been a trial run for us. So preparation has been a big key. Use of technology and well-defined roles and responsibilities have listed out already, and even minor sectors were involved. And the strong commitment from the political as well as administrative leadership has been the key towards involvement of all departments in the management of COVID-19 pandemic. And thank you. And
thank you so much, Dr. Jitesh, for that heartening, encouraging, inspiring presentation. And the way you have developed these robust health strategies, public health strategies. This will can be replicated in the rest of the, it's quite an ideal scenario that you have created. And with these multi-sectoral expert committees that you formulated, the multi-department teams that you have made, and the coordinated mechanism for prevention and response that you've adopted. It was also heartening to know about this Bhumika concept, and we hope, we wish you all the luck for your future endeavors. We now take it over to Shri Muzaffar Ahmed ji, who is the former member, National Disaster Management Authority. He has also served as the Director Health Services, Government of J&K. He is a public health medical expert with more than 28 years of experience, having worked in various positions in this field, and has written more than 6 books, besides over 110 publications in reputed national and international journals. Presented research papers in scientific, national, and international conferences. Over to you, Dr. Muzaffar ji. Dr. Muzaffar?
And
yeah,
now it is there.
Yeah.
Let me first thank the Sphere, Vikrant, and all other people who have organized this webinar for giving me opportunity to be here. And I'm happy to share my thoughts on what is required to be done I'll just, let me share. I'm just trying to open, it's not further. I have, have you been able to see my presentation? Yeah. Hina, how much time is there?
8 minutes, sir.
8, oh, so I'll have to then quickly go through my
presentations.
Yeah. You know, when we talk about the preparedness for health sector for emergencies, as you know, the sudden occurrence which demands an immediate action, maybe in epidemic, pandemic, or natural or even technological catastrophes. And risk, and not to go in the details with regard to the health risks which are happening in the health sector and which the health sector is facing in its approach for providing the best possible services. So what is required really is a whole health approach which has to be adopted. As many countries and communities, we cannot afford to have parallel planning and coordination system for each category of health risks, and plans of health sector therefore have to be made for all risks and hazards, and in coordination with SDMA and DDMAs. And we also need to have a good and adopt the national policy. Although we have the national policy on disaster management, but with regard to the clear policy on disaster prevention management with regard to the health sector, and creation and adoption of the standards, which is important, because these standards, procedures, manual, protocols, and regulations that reduce the health sector's disaster risk and also facilitate the work in the network of health facilities. Although we have NDMA guidelines, and this time in the pandemic, Ministry of Health issued quickly various protocols and SOPs which have helped. And what is also required is the participation and mobilization of other sectors, for which the platforms like national platform play an important role. And what is also is important is that DRR has to be incorporated into the developmental activities of all the programs and divisions of the Ministry of Health, not only at the national level, but also at the state and district level. And when we talk about the public health system, we have to ensure that the NGOs, religious groups, all people, all the actors are involved in the preparation and preparedness for the emergencies and disasters. And focus has to be given on the health services network, whether they are in private sector, they are in corporate sector, railway, they are in army, central police force, and others. And also what is required is emergency care services. We have to develop and ensure that our emergency, both in the hospital settings and pre-hospital care, is requires the definitely attention, and a special challenges for this pre-hospital care is especially in the rural care rural areas and tribal settings. And we have to also ensure that the issues which are important, like flow of information, workforce, and also patient safety, basic clinical and health services, research and treatment protocols are important. And what is really required in our country is AMS, emergency medical, how this responds quickly. And I would also like to say protection of our healthcare facilities is very important. Safe hospital concept is to be ensured, for which we need to have training. As we have seen, why focus on safe hospitals? We have seen large number of healthcare institutions crumbling in various, whether it was in Iran or even in Gujarat. And we have to ensure our hospital safety, because our hospitals are vulnerable. There is lack of preparedness in hospitals. And even if with the external disasters, earthquake, floods, we also have internal disasters in hospital. We have seen large number of disasters, whether it was floods, whether it was even in Srinagar, where all the major hospitals, tertiary care, even in Tamil Nadu, Chennai, and all places, the hospitals have suffered. Even one of the major problem is the fire in hospitals, which we have seen over the years. Even in the, not only in the Amri hospital, which was the first, but also the AIMS hospital, which was caught in the fire, and which gave us an idea and that where we stand with regard to the safety of hospitals. which is an important thing. And a safe hospital, it's not only the structural, but also non-structural and functionality of the hospital, which has to be there. That hospital should not collapse. There should not be any fire. There should not be power failures, water supply, terrorist attacks, and also the hospitals have become very casualty because of our chronic weak health systems, under investment in the health, poor facility location designs, and we had no emergency plans, no disaster management plans in hospital. And we should ensure that hospital should not only collapse in disasters, but it should be sound in its structural and also in non-structural elements and functional, because all these are important. Although relocable hospitals, modular hospitals, like in what was done in China and many other European countries, even in India, pre-engineered buildings have helped during emergency, and especially in COVID mode, where even the containerized hospitals in some countries were used. But the basic factors is that the hospitals have to be safe, and there has to be sharing of responsibilities by various actors, whether they are the engineers, architects, other universities, and also because if we lose a hospital, it's not only the economic investment, but the destruction of the functionality. It poses a major economic burden. And in the NDMA, we have one national guidelines on hospital safety, which was issued in 2016. And what is also is required that every hospital have a plan which needs to be activated immediately as and when the emergency occurs, and with an effective incident command system for commanding, controlling, and coordinating the efforts within the hospital and also outside the hospital when we have to send the rapid response team, because this incident command system gives greater efficiency. There is standardization, flexibility, and allow persons from different organizations to use a common management structure. This is very much important, and that we have not only the incident command system, we have plans, we have communication plans for epidemiology, surveillance, and laboratory. And when we talk about the health emergency, which is the lead agency for surveillance or for providing the rapid response, but if we have good advanced planning, training capacity of our workers, advanced stockpiling, and what is important is leadership at all level, which has to be with compassion, with transparency, preparedness, well-designed plans, which should be simulated, and there should be mock drills, periodic mock drills. And what is important is resilience. What we have talked about, the functional resilience, which is important in the health sector. If health sector is resilient in the normal times and in emergencies, will not face any problem, because it should be the public health infrastructure should be able, like what has the experience in many countries and even in our country has infrastructure capable of identifying, tracing, managing, and treating cases. We should have ability to undertake effective risk communication, fundamental, financial resources which have been, which we have seen in our country were provided for not only for personal protection equipment, but also for other essential equipments. And what is important is strengthening of government infrastructure along with private-public partnership, which shall have to be given thrust in the next few years, and for which we need to spend money, financial resources. We have to increase the spending to at least to 2.5% of the GDP. And we also have now, which we used to have, rely on the international pharma supply for bulk, which we have to now ensure that we have to stress on manufacture, and a strong pharma industry has to be there, which has been always pillar of affordable healthcare in India. And besides the medical equipment, which we were over-reliant on China and other countries, and even the personal protection equipment and diagnostic kits, now we have been able to manufacture, but in future also with research and other innovations we need to do in this sector well, and also the use of technology in telemedicine, training of our primary healthcare worker, and also ensuring that we have adequate mobile hospitals and various regions which have to be put on the simulated and drills. Although we have a legal framework, not only at the international level in the shape of international health regulations, even in our country, we have large number of regulations starting from 1897 Epidemic Act, Disaster Management Act, and Biomedical Waste Management Act, Air Prevention and Pollution Control Act, and also these legal frameworks. And also now we are going to have Public Health Emergency Act. And what I will like to say, that our country has the signatory of Sendai framework, where we have to reduce the disaster damage to our critical infrastructure by 2030, for which we need to work on how we make our health system resilient. Also, if we talk about a sustainable SDGs, and we have to ensure healthy lives and promote well-being at all levels, and emergency care for the SDGs, in fact, detailed not only for the treatment of the emergencies of ladies, but children, acute infections, sepsis, and so on. And by 2030, we should be able to reduce the number of deaths affected by the disaster, which we are. And what common mistakes we do in the disasters and emergency is either we have no planning or inadequate planning. We have seen that failure to bring the stakeholders into planning and testing of plans, and also failure to gain support from senior managers has been there. Thank you very much.
Thank you so much, sir. Thank you. It was indeed a very exhaustive, a very informative session. And thank you for sharing your rich experiences. We will try to incorporate some of the suggestions made by you in our handbook. Due to the paucity of the time, we will have to restrict the time for each speaker. So I would request the subsequent speakers to limit their sessions to 5 minutes. We are really very sorry, but then we're running short of time also, and I see a lot of questions on the chat box. Would we want to take some questions right now, or do we do it at the end of the session? What do you say, Vikrant, Ilya?
Dr. Henna, since we are going late, let's continue with this panelists first. And then at the end, if there is possibility, we'll take the questions. Thanks.
Okay, indeed. So now we call upon Ms. Sangeeta Tikiani, who has 15 years of rich experience on the public health system strengthening, policy support, quality assurance, formulating program strategies, outbreak management, monitoring and evaluation, and research. She is trained and certified by pioneer institutions, universities, including John Hopkins, Bloomberg School of Public Health, having served in many senior management positions in PHFI, and has vast experience not only nationally but at a global level. She is currently working as the founding director of Dr. Ask Healthcare at Home, and we invite you, Sangeeta, to this panel discussion. We would request you to limit your session for 5 minutes. So over to you, Sangeeta.
Thank you, Dr. Henna.
Yeah, we can hear you.
Great. Let me share my screen. Can you see my screen?
No, it's not visible as of now.
Just a minute.
Yeah, now
Now?
it's now.
Great. Yeah.
You can
Well,
zoom it up.
Yeah. Is that okay?
You can zoom it. Yeah.
Yeah, great. Well, thank you, Dr. Hena and Spare India. I can understand the time constraint that we have it, but my previous panelists have made my job easy. I'll be focusing more onto my key 2 slides and thereby sharing my experiences from the field. So just to connect the dots, as we say, emergencies when your procedures are interrupted and you need emergency response. So it needs to be managed. If you're unprepared, the communities will become vulnerable. So that's where the importance of the health systems comes into place. But important here is the health preparedness. That is what is essential. Important that I want to focus here is the preparedness and not preparation. Because if you are prepared, then you're focusing on the health systems. You will be building health systems. It's not event focused. So that will help you to have your platforms in place, operating systems in place. Now, for the district level preparedness, if you have this early action protocol in place, you will have your allocated resources and you'll be able to respond also. For this, your public health system is very important. And as they say, when we talk about the district health infrastructure, the first thing that comes to our mind is the physical infrastructure that people focuses on. But I want you to shift your focus on not only to physical infrastructure, but think through it from the 6 building health system building blocks and prepare your district infrastructure based on this. Leadership and governance, health workforce, medical products, vaccines and technologies, health information, health financing, and service delivery. To give you quickly about what we can do, and then I'll share my experiences of what could happen if you're not prepared for it. So when we talk about leadership and governance, you need to have that capacities have been built, that your entire team at the district level is well aware of your policies, the policies as in place, the different guidelines that you have it. Like in one of the districts where we were going and we were trying to tell them how important it is to you for you to have a license for fire safety. The immediate response that came is, oh, we are government. We don't take licenses, we give licenses. Who's going to give license to us? Now you need to understand, you are government that you know it, but that fire doesn't know that this is a government facility. So that kind of a mindset also needs to change, and you have to see that you all have to abide to this. Like human resources. So you need to have human resource database in place. You need to ensure that they have been well trained. Now, when I talk about human resources, at times what we do is we all know there are resource constraints that are there. What we think about is, oh, we have a shortage of staff and this and that. But you need to think out of the box. All those resources that are available. If you talk about ASHA workers, Anganwadi workers, the frontline workers that are there, the volunteers that are there, try to tap them, have their databases. Like Vijesh talked about the Kerala model, where they had tapped all these volunteers. This is going to help you. Financing. You need to have a realistic assessment of your cost recovery activities, that the government funding, the different global funds that are available. We need to avoid the wastage here. That's what is more important. Now, when I talk about medicines and technology, you have to ensure that you have essential supply of medicines and drugs. Try to avoid stockouts. Try to avoid expiry. Try to avoid pilferages. This is where your technology also comes in place, that with a click of a button, you should be able to know how much stock do you have, or you have a standardized list of the drugs that you require, so that you don't end up into expiry, but at the same time, there are no stockouts. There should be mechanisms in place that within districts, you should be able to mobilize and supply these medicines at the places where it is required to the population that is in need. Information. This is very important. You need to have your health information system in place. your epidemiological surveillance, and early warning systems. Again, timely management and timely information is very important, especially into these kind of an emergencies, because no point of having an alert once that incident has already happened. So do we have these systems in place? Are our different information systems integrated? Can I, with a click of a button, get the information that I want and mobilize my resources accordingly? All these needs to be done. The last and the most important that I want to focus here is your service delivery. Consider this to be the heart of your district health infrastructure and one of the main building blocks. You have to strengthen your primary care services. You have to plan for it and you have to restore your service delivery immediately. Like the examples that were shared from Gujarat, we know that our own emergency department was actually under these bombs. So what to do? Your entire planning system comes to standstill. So you need to have your backup plan available for this. How are you going to restore your service deliveries? Because your community knows this is the place to go. How do you communicate these kind of things? This is very important. Like at one of the places where we were trying to help them to develop their disaster plans, and we asked the district health authority, they said, oh, don't worry about chemical disasters. We have only 5 industries. And to our surprises, when we tried to tap it, there were 185 industries in that district. Important is to understand when you're talking about an infrastructure, don't look at the headquarter where you are. You need to take holistic. And if you don't know it, if you don't have enough information, you will never be able to prepare. And with whatever preparation that you have it, your infrastructure will not be sufficient because the data on which you have based entire thing in itself is not correct. I would quickly summarize with these key messages. Please remember, preparedness is the key and not the preparation, because that way you will strengthen your health systems and not an event in itself. Focus on all this. Focus all the 6 building blocks of health system strengthening and not only physical infrastructure. Your more focus should be on strengthening infrastructure for prevention and not only on treatment and cure. Well, the National Health Record says that there was only 7% of the total fund that was allocated to prevention. More than 80% was used for treatment and cure. That's where the whole flaw is. Primary care is important. Referral system needs to be strengthened. Otherwise, your entire preparation is going to go in vain. With whatever preparedness that you do it, you will not be able to tackle. As rightly said by Dr. Ahmed, PPP, public-private partnership is important. Government alone cannot handle the battle with whatever resources that you have it. So tap into the different private players, involve them from day one. Ownership is something which is very important and that can be built over years and through coordination. Here, important thing, last message that I want to give you is avoid pseudo specialization, where you only focus on your program, your resources, your infrastructure, but rather strengthen the overall district health infrastructure by multi-sectoral approach. As I said, alone government cannot do it, alone health sector cannot do it. It has to be multi-sectoral approach. Thank you, Henna. I hope I'm on time. Would be
Thank you
happy
so
to
much,
answer
Sangeeta.
questions.
Thank you so much, Sangeeta. Very informative presentation, highlighting the importance of these 6 core health system building blocks that you've talked about. I would quickly hand it over to Dr. Ibrahim Ali Ahmed Ji, who is the medical officer and in charge and holds the position of district surveillance officer for the district of Kakkar in Assam. He looks after achieving good health on different state parameters for his districts. He will be deliberating on strengthening district coordination for emergency response. Over to you, Dr. Ibrahim.
Thank you.
Dr. Ibrahim, are you there?
I don't see him in the list of participants. Maybe you can move to the next.
We can move to the next panelist, Dr. S. Vivek Adish. Sir, who is a professor and head of Department of Community Health Administration, National Institute of Health and Family Welfare. So do we have him here? Dr. Vivek? Dr. Vivek, are you there? Okay. I think he's not there. Dr. Rafi Arshid, are you there? Rafi Arshid? Hello?
I can't see him in the panelists, in the participants.
Okay. Let us move to Dr. Ritu Chauhan. So, Dr. Ritu, are you there?
Yes, Hannah, Dr. Ritu is there. Maybe you can introduce and then invite.
Dr. Rituji is the National Professional Officer, International Health Regulations of WHO India. She has more than 10 years of experience in policy strategy and planning on IHR, and her interests include food safety, zoonosis, and One Health and antimicrobial drug resistance. Presently, she is responding to COVID-19 response in India as part of WHO Health Emergency Team. I invite Dr. Ritu Chauhan to deliberate on health sector preparedness for disaster response. Over to you, Dr. Ritu. Dr. Ritu, are you there? Probably some technical glitches.
Let me call her on phone then. Yeah.
Hina, you can call other speaker, whosoever is available.
Yeah, Dr. Gupta. We also have with us Dr. Ravikant Singh ji. Ravikant, are you there? Ravikant, Dr. Ravikant? He is not there on the...
I think Dr. Ritu has joined with some other device, requesting the host to please make her co-host.
Yeah, Ravikant is here. Dr. Ravikant, are you there? Yeah. So, Dr. Ravikant ji started
Yeah,
doctors
thank
for
you.
you. He started doctors.
I
Let me
was
just
on mute.
introduce you for you. Ravikant ji started doctors for you in 2007 when he was still a medical student of KEM Hospital, Mumbai. He spends a greater part of the year leading teams on medical relief work and training healthcare staff. Regarded as the country's foremost medical relief specialist, he has worked from Chennai to Kashmir to Uttarkashi and Bihar and continues to inspire us all. We welcome you all. We welcome you, Dr. Ravikant, and over to you for your session on challenges in ensuring coordination in health sector during emergencies.
Great. So thank you, Hinaji. Nice to see you after so long. And Muzaffar sir also. I would not take much time. Just 3 points I wanted to highlight. Already, like the various challenges, many speakers have already discussed. So the three things I want to say is, the first is the leadership, responsible leadership during emergency. The second is the need of one health approach, and the third is funding. So the first is leadership. If you ask me, especially for the public health response, we are still facing huge shortage of. We are still facing huge shortage of leadership crisis. We have very few limited expert on public health emergency, and I would say this is the opportune time when WHO should take the lead in this front, because one of the major challenge we face is communicating with various stakeholder who has like limited understanding of the public health emergency, need to respond faster, and the subject expertise. So I don't think, apart from WHO and the few people from the UNICEF, we need to develop leadership for public health emergency preparedness, and now more than normal emergency, especially pandemic preparedness. The second thing is, as I think one speaker said, the funding. The funding is very important. Without dedicated funding to for the emergency preparedness, and especially for the now, as we know, pandemics are very frequent. So for the pandemic preparedness, we need separate dedicated fund, and unless until the state government and government of India and globally also, if we don't dedicate the separate funding to build the public health preparedness, it's a very difficult to mount the response immediately after any disease outbreak, especially when the diseases like COVID or other infectious emerging infectious diseases. The third major challenge, I think, is our focus is too much on the human health approach. But if you see the now we are talking about one health, where the animal health, environment health is also, or I would say, more important than the only human health. So we have to see these three things: human, animal, and environmental health. In fact, recently, just I think last month, in Japan, there was convention on biological diversity, and you will be surprised to note that in 2010, globally, we have set up 20 target to achieve by 2020, and we have failed to achieve even one single target out of those 20 targets. So if we keep on destroying our environment, and if we don't invest in animal health and the building public health capacity, it's very difficult to coordinate and mount the more than the funding and these three things, especially the responsible and proactive leadership, one health approach, and the funding is very important to have proper coordination and response from during such emergency, Hina. Thank you so much.
Thank you so much, Dr. Ravikant, for this very insightful, for sharing your rich insights and valuable suggestions, which will go a long way in being incorporated in our handbook. Thank you so much for all the good work and hard work that you're doing out there in the field. Our good wishes are always with you. We would now like to call upon Dr. Ritu Chauhan. Is she there? she's
Hello,
there, but I
am
think
I
she's busy
audible?
with something. Yeah.
Hina, am I
Yeah,
audible?
Dr. Ritu. Yes, you are loud and clear. Dr. Ritu Chauhan
Okay.
ji, the National Professional Officer, International Health Regulations of WHO India, has more than 10 years of experience in policy, strategy, and planning of IHR. And her interests include food safety, zoonosis, and One Health and antimicrobial drug resistance. Presently, she is responding to the COVID-19 response in India as part of WHO Health Emergency Team. We tried to reach to you a little earlier, but I think you were in another meeting. So we welcome you, and we would like to hear from you on the health sector preparedness for disaster response, Dr. Chauhan.
Thanks, Hina, and thank you to NIDM, Sphere, other UN agencies that have got together to organize this webinar, which is very important. I think we are at the cusp of really looking at how strengthening the capacities for international health regulations leads to effective pandemic preparedness. And clearly, as countries are responding to the currently ongoing COVID-19 pandemic, we understand that many of the realities that what we are facing today is because of the way the world is changing. Our population, the density, the level of international travel which is happening, the rapid scale urbanization, weak public health infrastructure, adaptation of microbes, emerging antimicrobial resistance, and all the One Health issues of spillover from one species to another to man, and climate change. These are some of the very high risk factors under which the world is currently operating, and all this threatens the global public health security. We're also seeing that almost 20 million people are displaced every year due to extreme weather events. And in our own country, many states continue to have natural disasters. And we have been discussing for the past couple of months also on how states should be prepared and are responding to some of the concurrent disasters, including having to respond to COVID-19. So really this affects the health and survival of mankind. We are seeing the very quickened pace also at which pathogens are jumping from animals to humans. And if you see, there's almost a new pathogen emerging every year. And we were literally not even done with the Ebola virus disease in the world that we happened to encounter the COVID-19 pandemic. And we understand that 75% of this is the emergence of these newer pathogens is from the animals. So really living safe with animals will be the longer term development challenge in preventing the emerging diseases. We're also seeing market failures in public health. So governments really need to take greater responsibility in the defense against infectious diseases and biological threats. And therefore, WHO has been advocating for pandemic preparedness for a very long time. So we are talking about greater investments for health, for prevention, for disease surveillance and response, biosafety, hospital infection control, but of course, making sure that treatment of infectious diseases is available and accessible to all. We are also finding that the emerging infectious diseases are very significantly correlated with socioeconomic, environmental, and ecological factors. So these are also very important considerations for us as we move forward in terms of more investments to healthcare. As you know, that Ebola worldwide was really a global wake-up call, and it really highlighted that insufficient numbers of healthcare workers, not enough qualified healthcare workers, inadequate surveillance and information systems, absence of rapid response teams, fewer laboratories, unreliable supply and procurement systems for personal protective equipment and other supplies, fewer ambulances, and limited public health education amounted to weak health systems. So really, if we are talking about a multi-sectoral approach, we have to talk about health systems resilience and how the health systems capacity can be worked on, not only at national level, but also at sub-national level. When we really talk about that, we talk about an enormous and robust response capacity that needs to be there at our district level, at our local level, not only in terms of the human capital, but also the operational, logistic, financial, and other requirements which are needed. We also know that some of these zoonotic diseases are very notorious for making a comeback. So when we saw Ebola re-emerge in DRC, we understand that these are going to be some of the challenging events which the world will continue to face. Influenza still remains a continuing public health threat, and we are now talking about how to prepare for the coming flu season, even in the context of COVID. We understand these pathogens are unstable, they are unpredictable, they will have potential for catastrophic impact if there is a surge of cases. And therefore, we also need to understand that right now, since most of our laboratories are currently responding to COVID-19, how in the context of that will we be taking care if there is were to be a flu surge. So we know and understand that history is very important, and we need to learn from our previous pandemics as well. And we were going through some of the literature also of the 1918, 1957, 1968 pandemics, and how some of those, the way history is repeating itself, and some of the lessons that were learned in the earlier pandemics are also proving to be useful in terms of responding right now. What we really are talking about is more investments in terms of surveillance for both the seasonal strains as well as the pandemic strains, but constant vigilance and timely sharing of viruses, virological data, and epidemiological and health information is also critical. While we know that the world is moving towards having better therapeutic and breakthroughs in terms of vaccination, we also understand that a lot will depend upon the way our communities are responding. And therefore, there is so much need for ensuring that the risk communication is ever invested into. So we really need to have communities engaged with. So we need to work. 2019, our Director General, Dr. Tedros, had made a comment at the launch of the Global Influenza New Strategy. And he said, I quote, "The threat of pandemic influenza is ever present. The ongoing risk of a new influenza virus transmitting from animals to humans and potentially causing a pandemic is real. The question is not whether we will have another pandemic, but when. We must be vigilant and prepared, and the cost of a pandemic far outweighs the price of prevention." So really, we have been working with countries for pandemic preparedness and response, and we find that countries that have invested sufficiently in capacities for IHR have been able to respond more effectively in terms of responding to the COVID-19 current pandemic. I also want to state that since IHR is the only internationally agreed set of rules which is governing the response to outbreaks of infectious diseases and public health emergencies, really it is upon the countries to keep each other informed about the public health risks as WHO continues to work with member states and partners to build capacity to detect, report, and respond to public health events. And since IHR has a broad scope, we are really talking about moving from the known risks to the unknown risks and building on existing systems and resources, not another vertical program, but working towards sustainability and moving from preset measures to adapted responses. So since the principles of IHR, I want to restate, and I think it's very important as we build global solidarity, especially at a time when countries are tending to go solo. We really need to talk about greater transparency, mutual accountability, building trust, appreciation of global public health benefits, dialogue, and sustainability. So this is really a time where we need to have more focus, more investments into the IHR capacities, as we know that the world will continue to see these extraordinary events, which will constitute a public health risk to multiple countries. So since IHR core capacities not only talk about surveillance and response, but are heavily hinged on preparedness, risk communication, investing in human resources and laboratory infrastructure, as well as legislation and policy, not only for infectious hazards, but also for other hazards, I do want to here also mention the wonderful role which has been played by the surveillance officers at points of entry, because we know this is the first line of defense when we are talking about global events that, travel through trade and international travel. So I will just stop here and say, as a final point that what we really need is timely and appropriate messaging, working with the communities. We know there are challenges. We know that more investments are needed, but there is wide consensus that international health regulations does help the international community to manage acute public health events and emergencies better. There is now renewed need to invest in better response, prevention, and detection capacities now more than ever. We also need to look at how do we move beyond some of the indicators and attributes that are there within the IHR capacities to better understand what kind of collaborative efforts are needed between different sectors and agencies. And we know that here is a role that everybody can play, whether it is a private sector or a government institution or CSOs, NGOs. We really are talking about whole of society preparedness. We have to move from an event-based to a risk-based approach, from a reactive to a proactive approach, from a single hazard to an all hazard approach, and really talking about whole of society. So we are at the cusp of where we have shared responsibility for investment in health systems, and the response focus has to be on risk management. We really need to move from planning for communities to planning with communities. So I'll stop here, Hina. Thank you for the opportunity.
Thank you so much, Dr. Chauhan, for sharing your perspective on emphasizing the robust health sector preparedness for effective disaster response. Before we proceed to the question answer session, I would request Professor Anil to summarize, to share his perspective on the panel session and to summarize some of the key recommendations laid during the session. Professor Anil. Professor Anil. Professor Gupta? Professor Anil Gupta? Professor Anil, are you there? All right. Let us take some questions for the session. One of the participant has asked that in the event of the new normal situation developing throughout the world with the influenza of prolonged COVID-19 pandemic, what are the changes proposed in the guidelines to deal with health emergency in natural disaster response system, that is hydrological disasters? So anyone in the panel who would like to respond to the question?
Hina, can you please repeat the question?
Yeah, I'll repeat it for you, sir. In the event of new normal situation developing throughout the world with the influence of prolonged COVID pandemic, what are the changes proposed in the guidelines to deal with health emergency in natural disaster response system, that is specifically talking about hydrological disasters?
Yeah. You know, if we talk about the biological disasters, almost number of countries have guidelines. They have been working immediately after the Ebola outbreak and in the influenza outbreaks in the past. There have been guidelines, and what the question was about the hydrological, the after hydrological disasters. Many problems like Japanese encephalitis in India, in eastern UP, Bihar, and some areas immediately after floods were getting a large number of deaths and cases, for which the guidelines were framed, for which the national program by 6 ministries was formulated. And with the climate change, the number of vector-borne diseases have also going up in many countries, which is an area of concern for which in the coming years also a lot of efforts have to be taken up to
Professor
see
Gupta,
whether it is
Professor Gupta,
dengue
can you please
or
unmute yourself?
chikungunya or other diseases. Thank you.
Thank you so much. Professor Gupta, are you there?
Hello.
Yeah, Professor Gupta.
Ji.
If you can please summarize the panel session so that we can conclude. And I don't think we have more speakers on the panel as of now.
Yeah, so thank you for coordinating this very nice, very nicely this panel discussion. And what I would, if we take 4 or 5 key points, and as Dr. Muzaffar Ahmed Saab has been referring, in fact, he is the person when he was with NDMA also, we have always been talking of this subject, that this is very, very important. And as this subject is now getting impetus, so this will be a really very good initiative to come up with some kind of a guideline or some kind of a sectoral manual to help the people working on various aspects of disaster response and relief. But if we take kind of a few points, I would say that simple, besides this kind of guidelines and plans, a simple awareness materials are also important, not necessarily in the form of books, because now in the COVID and post-COVID period, now we have started saying that we have to go more virtual. So maybe the small video clippings kind of things also. So that also has emerged as that how we have the new thought about this awareness related endeavors. Then how the intersectoral issues can be looked at, particularly at the local level, because the speakers referred on this point also, that health itself is a multi-sectoral dimension. So on one hand, we find that health is a sector, but it is depending on, or it has very close linkage with other sectors. Water is one, then maybe ecosystems and biodiversity have that is also direct relationship. Then if we talk of infrastructure, then certainly the knowledge domains, forecasting methods and all these things come into picture. Then infrastructure comes into picture. So housing, because all the hospital and hospital facilities, it requires buildings. So the building, this housing sector comes into picture, housing construction related issues. Then and there are two type of interdependencies which I think we may consider. That one is the dependence on the health sector on other sectors. Maybe if we take example of a district or a city, so for example, if the hospital is intact but the road is not intact, so roads are not all weather roads, then patients cannot reach to hospital, or the doctors cannot reach to patients. So the services of hospital or services of health sector will depend on other sectors. So that kind of interdependencies. But on the other hand, within the hospital or within the healthcare facility itself, then for example, the functioning of the hospital wards depending on the backup electricity or backup power supply. So and during disasters, what happens that power, communication, water, these are kind of the primary victims. These sectors are the first thing to get affected. So how we have the backup facilities. Then waste management, as the previous discussion, the discourse in this series was on Watson. So how the waste management facilities within the hospital and also in the city. So how this aspect has to be looked into this. So these kind of things, if we take example from Orissa, During the cyclone Fani, what happened because of the high wind, the pipes connecting the water supply tanks got blown away, and then the water supply got disrupted, and on the other hand the entire water from the tank got into the wards. The kind of everything was in a floating condition, but on the other hand there was no water available. So health within the health facility and the interdependence outside. So these are also very important dimensions for health sector resilience, or health service resilience, I would say, more health service resilience during and after the disaster. And then bringing understanding of the importance of health otherwise also, and particularly during disasters at household level. That is very important. So when we have the awareness drive about disasters, so we can revisit all our do's and don'ts about various disasters. For example, we have do's and don'ts about floods, drought, earthquake. So can we integrate, can we also give some kind of a tips about the health related issues during those kind of disasters, and even before that and after that. So I think these are the points that I would like to present as a summary points here. Yeah. Thank you.
Thank you so much, sir, for summarizing the event proceedings and giving in your perspective. We have more questions. Can we take more questions? Does the time allow? I mean, can we take a few more questions?
Gigi.
One of the question that is coming from the chat box is related to inclusion of persons with disabilities. How can we make health policies of the country inclusive for all? Can any of the panel speakers respond?
Can you repeat the question?
How can we make the health policies of the country inclusive for all? And there is a special mention of persons with disabilities.
I think that all our health programs, including the health adaptation plan, is all inclusive. So I would say that there is no lacuna in policy. Actually translation of policies and then plans into actual operations on ground, that is the real issue. Policy wise we are not weak.
So
But certainly
implementation is the
when we implement, then the new lessons come, and then that is the reason we say that we need to be revisiting our policies and plans, and then we can further revise also. But as on date, those are inclusive of the disability related issues also, even the poor people, marginalized sections also, that is there in the policy. But how it is translated at local level, that is important.
So
Henna, can I just add to what Sir has already mentioned? So yes, I think it's a very important concern. And let me share with you a few perspectives when I visited Orissa state after Cyclone Fani. Some of the major concerns were that, there were people, many of the more vulnerable people, those who are disabled, those who were elderly, who could not, come out of their houses on their own. A lot of efforts had to be made by the district and local administration to ensure that sufficiently they were taken care of. So really, when we talk about, as Dr. Anil has nicely mentioned, that the policies are very well comprehensively spelled out, but it involves a lot of local actors, local administration, the police department, the other, even people from the fire departments, they were called to help all those who were disabled, those who were more marginalized, could not seek health access, health care. And whenever we have such disasters, we also draw upon the capacities of our the army, the other paramilitary forces, some of the others who also step in beyond their line of duty and also contribute towards ensuring that people are taken care of, especially in the aftermath of disasters. So really, it calls for a lot of engagement also of civil society and other actors. Even a lot of private sector agencies are now partnering for inclusive policies and contributing to some of these areas. So when we really, that is what we really talk about whole of society response. There will be areas where the government machinery might not be able to reach, but the local actors, the small NGOs, small CSOs, they are able to amplify the reach and the messages. So we really call upon the support of all actors when we talk about inclusive policies, especially in terms of its implementation. So over.
Thank you so much, Dr. Chauhan. So I don't think there are a few suggestions, and I don't see many questions there. Any more questions, unless somebody can kind of see any more questions. So we have sent you a feedback form. I presume that all of you have filled this, whoever's attended, and we would like to conclude this session. I would like to pay a special word of thanks to Professor Anil Gupta for spearheading this session and giving us some strategic directions of some of the recommendations and suggestions that will feed in the handbook. Dr. Jitesh, thank you. Dr. Muzaffar, Ms. Sangeeta, and Dr. Ritu and Dr. Ravikant. We're very thankful to you for giving, for spending your special precious time and sharing your rich experiences during the course of this session. So do we conclude, or do we have any, Ilya, you want to add something?
No, Dr. Hina, you can just hand it over to Anil or whoever is hosting for the administrative announcements. Thank you so much.
Hello. Hina, I'm audible? Hello?
Yes, Anil, you are audible.
Yeah, thanks. So thank you, Dr. Hina, for moderating this session. And I thank all the participants for joining. You can download your certificate from our official website, www.sphereindiacovid19academy.org. They will be available after 24 hours. And thanks again for joining. You can also register for our upcoming sessions by visiting our website. Thank you all.
Thank you so much, Anil. With this, we conclude the proceedings of the session, and we conclude the session. Thank you so much for being with us. Thank you.